In clinical cardiology, vulnerable plaque refers to an atherosclerotic lesion that is highly susceptible to sudden rupture, which can lead to thrombosis and subsequent acute coronary syndrome or sudden cardiac death. While traditional stable plaques cause progressive luminal narrowing and angina, vulnerable plaques are often non-obstructive, meaning they might not even show up as a significant stenosis on routine stress test before they trigger a catastrophic event. A vulnerable plaque is often characterized by the thin cap fibroatheroma morphology. Key features include large lipid-rich necrotic core, typically occupying more than 40% of the plaque volume. Thin fibrous cap. A cap thickness usually measured at less than 65 micrometer. This thinness makes the plaque structurally unstable against the mechanical stresses of blood flow. High macrophage content. Intense inflammatory activity within the cap leads to the secretion of matrix metalloproteinases, which degrade collagen and further weaken the structure. Intraplaque hemorrhage. Leaky vasovasorum due to neovascularization can bleed into the plaque, rapidly increasing its volume and internal pressure. Since these plaques are often non-stenotic, identifying them requires advanced intracoronary or high-resolution non-invasive imaging. Optical coherence tomography or OCT, the gold standard for measuring fibrous cap thickness due to its high resolution, 10 to 15 micrometer. Intravascular ultrasound or IVUS, better for assessing total plaque burden and the presence of a necrotic core, that is virtual histology IVUS. Near infrared spectroscopy NIRS specifically identifies lipid content, helping to quantify the lipid core burden index. CT coronary angiography identifies high-risk features non-invasively, such as positive remodeling, low attenuation plaque, and the napkin ring sign. The napkin ring sign describes the cross-sectional appearance of an atherosclerotic plaque on a CT scan. It is named for its visual similarity to a napkin held in a ring. Its characteristic features are low attenuation inner core. The center of the plaque adjacent to the lumen appears dark, low density on CT scan. This corresponds to a large lipid-rich necrotic core. Higher attenuation outer ring. The inner core is surrounded by a distinct ring of tissue that appears brighter, higher density. This ring is believed to represent the fibrous plaque tissue, or in some cases, a particularly thin fibrous cap that is prone to rupture. Plaque rupture versus plaque erosion. It is important to distinguish between two primary mechanisms of coronary thrombosis. Plaque rupture occurs when the fibrous cap breaks, exposing the highly thrombogenic necrotic material to the bloodstream. This is the classic mechanism of ST elevation myocardial infarction. Plaque erosion. The cap remains intact, but the endothelial surface is lost. This is more common in women and smokers and is increasingly recognized in the era of high-intensity statin therapy. The goal of treatment is plaque stabilization, turning a soft, vulnerable plaque into a hard, calcified one. Pharmacotherapy. High-intensity statins are the cornerstone of treatment. They reduce the lipid core size and increase fibrous cap thickness. Newer agents like PCSK9 inhibitors and colchicine for anti-inflammatory effects are showing significant promise in reducing residual risk. Systemic versus local. While some research has looked into sealing vulnerable plaques with bioresorbable scaffolds or stent, preventive stenting, Systemic medical therapy remains the primary approach because vulnerable plaques are usually a sign of widespread pan-coronary disease rather than a single focal problem. The vulnerable plaque concept has shifted slightly towards the vulnerable patient, recognizing the systemic inflammatory state and blood thrombogenicity are just as important as the individual lesion's anatomy. The concept of vulnerable patient can be described as a patient presenting with a combination of multiple risk factors and or extremely high risk levels of one of the core risks.